Good evening. It gives me great pleasure to welcome you to tonight's webinar on pneumococcal disease. This webinar is dedicated to the late Professor Alan Cripps. My name is Anita Munoz and I'm a practicing GP and GP educator and I'm from Melbourne. In the spirit of reconciliation and on behalf of the Immunisation Coalition, I would like to acknowledge the traditional custodians of the various lands on which we work today, in particular the Wurundjeri people of Melbourne, where I am from, and to extend that welcome to all Aboriginal and Torres Strait Islander people that may be participating in this webinar. I would also like to pay my respects to elders past, present and emerging, and celebrate the diversity of all Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. Tonight's topic is protecting children and older adults from invasive pneumococcal disease. Joining me tonight, we are very lucky actually to have three panel experts. Firstly, Professor Paul Van Bunder. Paul is a public health physician at the School of Medicine at Griffith University in Queensland. He has held several senior public health positions in Australia, Canada, and in the UK, and is a past chairman of the Immunisation Coalition. Paul is a reviewer of over 10 journals and has over 80 referred book chapters and articles. So welcome, Paul. Next is Associate Professor Michael Woodward, who is Head of the Aged Care Research at Austin Health in Melbourne. He is a specialist of geriatric medicine with a major interest in adult vaccination, Alzheimer's disease and other dementias, wound management and the quality use of medicines in older people. He is also the head of the Medical and Cognitive Research Unit, the chair of the Geriatric Therapeutics section of the editorial board of the Journal of Pharmacy Practice and Research. And to his credit, has over 130 peer-reviewed research and review articles. So welcome to you, Michael. And finally, Dr. Phoebe Williams. Phoebe is a paediatrician, infectious diseases physician, and a senior lecturer within the School of Public Health, Faculty of Medicine, University of Sydney. She works as a clinician at the Sydney Children's Hospital Network and within the policy group of the National Centre for Immunisation and Research Surveillance as part of the policy team, the support team for ATAGI. Phoebe completed her Doctor of Philosophy as a Nuffield Department of Medicine scholar with the University of Oxford, undertaking a clinical trial for neonates with sepsis in rural Kenya. Phoebe is an NHMRC Emerging Leader Fellow whose research is focused on antimicrobial resistance in children and leads the Neonatal Sepsis in Southeast Asia and the Pacific Consortium. Phoebe is also appointed as an advisor to the World Health Organization's Pediatric Antibiotic Development Program and Research Agenda into AMR on human health. Welcome, Phoebe. So just a bit of housekeeping before we start. Please use the chat function to send through your questions throughout the meeting. You can also use the comments tab to post your comments to other participants online. To respect everybody's time, we aim to finish at 7:30 p.m. sharp. Finally, we would like to acknowledge Pfizer and MSD for supporting this educational activity, and that the views of myself and the panel members do represent our own. Now, let's get started. I would like to ask Professor Paul back to provide us an overview before we begin the panel discussion. So welcome, Paul. We will see you after your presentation.
Thank you, Anita, for the introduction. So I'm going to speak only for about 15, 20 minutes. So this is obviously a truncated overview of what's happening with pneumococcal disease. I want to start by talking about Alan Cripps, who sadly passed away December last, or the one before, sorry. Most of us knew Alan very well. He was an amazing man. He actually was raised on a farm in New South Wales and schooled by correspondence, got a Commonwealth scholarship to Sydney Uni, where he got a Doctor of Philosophy, then did a postdoc in Sweden, and then actually was widely recorded. He was probably the foremost researcher in mucosal immunity, and led to a range of technological assays, helped with the development of mucosal vaccine and with protein purification. He was at Newcastle, Canberra and Griffith. And I think one of the most major things about his academic career is that when you have a look at the summary there, he mentored 47 doctoral candidates, which is a most astonishing workload that he went, and he was given an Order of Australia for distinguished service to tertiary education and to public health. He was a friend of mine. He was great to sit down with over a bottle of red wine, and we all miss him and are, delighted with the legacy he left behind in pneumococcal disease. This is my disclaimer. I have at times received funding from both of tonight's sponsors. I've consulted with both of them prior to the talk and received information and slides from both. However, what I'm going to talk about is my opinion, and please read the product information before providing any vaccines. I'm going to tell you about an exciting range of new vaccines, but then identify the fact that only the traditional PCV13 is funded in Australia for at least the next 12 months. So this is my view of current pneumococcal vaccine policy. On the left-hand side, for those of you who are as old as I am, you'll remember a guy called Bomber Beasley. He was the Minister for Science, and he put out this diagram of how to turn Australia into a knowledge nation. I think Barry Jones, the quizmaster, and Bomber Beasley were the only two people who understood what he was talking about. And I think if we ask general practitioners about the current pneumococcal vaccination program at different ages and for different conditions and who should get what and who gets boosted and don't, they will think that our vaccine policy is a little bit like knowledge nation. And so on the right-hand side is the risk conditions for pneumococcal disease. Previous disease, immunocompromising conditions, respiratory, kidney, liver, cardiac, diabetes, smoking, harmful use of alcohol, an enormous number of people at risk of pneumococcal disease. The vast majority of those do not qualify for a funded vaccine. So this is the principle of our current vaccination program. On the left-hand side is a summary from the Australian government on different ages, different risks, who gets what at different times, and whether they are or they are not entitled to free vaccine. On the right-hand side is the current principle. Children get 3 doses of PCV at 2, 4 and 12 months of age. Some children with Indigenous status or with at-risk conditions, extreme prematurity and so on, they get 4 doses. So they get the old 3+ doses, then they get their 12-month, and then they get 2 doses of 23-valent polysaccharide at 12 months later and 5 years after that. People diagnosed as being at risk and having a condition after the age of 12 months get 1 dose of PCV, and then they get 2 doses of 23-valent polysaccharide. Indigenous over 50 years get PCV and then 2 doses of 23-valent, and non-Indigenous over 70 years get PCV. And in Australia, all those bits up there that say PCV are for PCV13 as the only funded vaccine. So the pneumococcus is a gram-positive diplococci. It's surrounded by a polysaccharide capsule, which is the virulence factor and is the reason we classify them into different serotypes. About 20 serotypes account for the vast majority of invasive disease globally. And it is a bug that colonizes the nasopharynx. The degree of colonization varies with age groups. It probably peaks in adolescence, but it is available right through the age spectrum. In children, it tends to cause middle ear otitis media. It can go on to cause pneumonia, and in some cases, probably 10-15%, it gets into the circulatory system, causing a bacteremia, and then from there it can either cause meningitis or a bacteremic pneumonia. So these are the clinical manifestations. Pneumonia is part of all-cause community acquired. About 25% of pneumococcal pneumonia is invasive, and the other 75% is non-invasive. The bacteremia tends to occur with pneumococcal pneumonia, although there is some meningitis, and it is actually an important cause of meningitis now that we vaccinate very successfully against Haemophilus. Children with meningitis due to pneumococcus can get hearing loss, motor abnormalities, seizures, and mental retardation. So this is a significant disease, and particularly in older persons, because this actually is associated with a significant mortality. This is where we are in Australia. So we used to see lots of pneumococcal disease at the turn of the century, and then we started providing PCV7 on the NIP and PP and 23-valent PPV for greater than 68-year-olds in about 2005, although a fair bit of it was used in paediatrics before it came onto the NIP. And that top purple line is children less than 2, and you can see that it had an amazing impact vaccinating those children all the way down. By 2006, we're already getting near the nadir of invasive pneumococcal disease. PCV13 became available in 2011. We decided to replace PCV7 with that. The only difference being that the territory had 1 year of PCV10 beforehand. A decision was made to stop boosting with polysaccharide vaccine at that time, and you can see that it had some degree of impact for a year or two, but that we did start to see a return of pneumococcal disease to the sort of PCV7 levels by 2018. An analysis in 2018 showed that we were getting breakthrough disease, particularly in the 4 to 9-year-old group. And so these were people getting 2, 4, 6-month vaccines, but going on to develop it. And by comparison, this really wasn't seen in many other countries that were using booster doses. So we changed from our 3+0 to a 2+1 schedule of 2 and 4 months, and then the third one at 12 months. And we've seen a decrease in that 2 to 5 year group and in the 5 to 9 year group since that time. So a change in the schedule meant that we dropped down by 2020, at which stage the decision was made to cease polysaccharide vaccine for 65 plus and to introduce PCV13 at 70 plus, leaving a group of people from 65 to 70 relatively unprotected at that time. And so that's where we were. And I've stopped at that particular point because after that, the pandemic came and we started locking people up, closing schools, closing shops, and doing all of that. A lot of pneumococcal disease follows in winter from particularly influenza and RSV disease. So they predispose people to converting their carriage into disease. We didn't see much of those in 2020-21, and we saw a decrease in our pneumococcal disease at that stage, but it is bouncing back from now. I want to talk a little bit about ST3, serotype 3. Serotype 3 is what they call the sugar killer. It's got a big, thick vaccine, a big, thick capsule, and it tends to be covalently loosely bound so that the capsule splits off, and when we try and make antibodies against it, they get redirected across to these bits of capsule that are floating around, and neither PCV13 nor PPV23 really seem to have much impact on that. And those of you who've seen the recent paper about the impact of changing to a 2+1 instead of a 3+0 will see that it greatly decreased disease across the board, with the exception of serotype 3. And the fact that it really doesn't work that well for serotype 3 means that we have a problem with that. And these are the data from the US showing that we still have a problem, despite PCV13, including serotype 3, as a fairly significant proportion of our disease in vaccinated populations. And these are a couple of other examples of that. The serotype 3 in Hong Kong is greatly increasing in prevalence, despite the fact that we've been using conjugated vaccine for a while. And the problem with this is that it's actually a significant cause of empyema in Australia. It's now running at about 76% of these. So nasty disease, nastier disease than the other serotypes, and one that we're really not doing a lot about at the moment. This is a complicated graph, but I think it's important to try and understand a little bit of this before we actually get to the point of having other vaccines available. And so this is 2019, before the pandemic. PCV7, we still have a little bit of 19F floating around. PCV13, a quarter of our cases are actually due to serotype 3 that year. Those that were in PPV23 but were not in PCV account for a third of the cases, 30%, and they're 22F, 33F, 9N, and then a series of others. Not as important. I raise 22F and 33F for two reasons. One, it is actually in the two new vaccines that are licensed in Australia but not funded. And secondly, because it is a major cause of increasing antimicrobial resistance in countries like Canada, where it's about 1/6 of the cases over there. So this is the take-home message. To reduce pneumococcal disease, we need vaccines with good effectiveness against prevailing serotypes, and we need to use them. And there's a big difference between what Phoebe will talk about, the vaccine coverage in children and the vaccine coverage that we see in adults in Australia. These are our currently available vaccines. PCV7 and 10 are not around anymore. 13, 15 and 20 are conjugated vaccines that include PCV3. You can see that 13 and 15 also now include 22F and 33F, and PCV20 has a number of those other serotypes that were in that group that you can see in the middle of that particular picture in the light blue. So these two slides are on possible policies that we have. We have 3 vaccines in Australia at the moment for children. PCV13 is the stalwart. We've been using it for a good decade. It has less coverage against serotypes, but it's the only one funded at the moment, and it does contribute to herd immunity through carriage reduction. PCV15 has 2 extra, 22F and 33F. The NCIRS grade review said that, as well as being better than PCV13 for 22F, 33F, it was also better for serotype 3. Now, that's not based on real-world data. That's based on immunological studies, but it is used in PED programs elsewhere in Asia, like Singapore. Now, PCV20 has 5 additional serotypes above PCV15, so a broader coverage. But it's probably not going to address serotype 3. There's no guarantee that PCV15 will, but there's a chance. And there were some issues with some assays. I mean, there were different assays done. It did better against OPA than others, but it didn't meet early dose non-inferiority at the 2 and 4 month program. So this is improved in Australia and other countries for children. But in some countries, because of the early concerns, it's only approved as a 3+1, not as a 2+1 like we run in Australia. These are the adult possibilities, PCV13 again, PCV15 again, and it is used overseas in adult programs, but actually it's usually used as an alternate to PCV20 with a recommendation to give an additional dose of polysaccharide vaccine. So in adult programs, it's a 2-dose thing elsewhere. And PCV20, which we've been through, is used overseas in adult programs on its own without the additional 23-valent. And I want to just mention PCV21, which is coming at it from a different angle in that it doesn't cover some of the serotypes in PCV7 and 13. It assumes that we already have herd immunity and they're not causing problems later on. And it also assumes that we can't just keep adding more and more vaccine serotypes because in the end they interfere with each other and we don't get protection. And so what it's doing is saying, here's a batch of different ones that we don't have in anything, and we're going to add them within the 21 instead of the originals. And so that's something that has not, to my knowledge, had a recommendation at this stage in Australia, although it has elsewhere. And it's an alternative to PCV20 or PCV13 plus polysaccharide 20 for older people. And I'll stop there so we can get to the discussion. Thanks.
Thank you so much. Paul, my mind is all a whirl, and this is so much more complicated than it seems at the outset, particularly when you make a statement, which I wasn't expecting, that too many serotypes in vaccines can cause interference between one vaccine and the other. You may have blown my mind there, because my question was, why don't we just all use 23? That seems to have the most serotypes in it. So there's a lot to this that requires some explanation here. I want to talk, first of all, about why this is, without becoming too political, but can you give us the obvious question from this that's come through is, why are we not yet funding this vaccines? Do we think that there's going to be a change in this soon? Do we think that we're going to be getting a new schedule again? Any comments about where Australia might be heading in the light of this new science?
Yeah, thanks for that, and thanks for the question from one of the participants. There is actually a pneumococcal review currently underway, and I'm expecting that towards the end of this year or early next year that will be published. I think, look, Australia has an ageist approach to vaccines. We don't fund RSV, we don't fund this particular vaccine for people who need it in most groups, and Australia has, as in fact all countries in the world, a fairly poor record of getting good vaccine coverage in targeted vaccines. If we say, look, it's only good for people with A, B or C, we really do not get decent coverage. We see that with flu and various others. And so I think that's one of the issues. One of the issues is we just don't fund vaccines for people. The other part of that is that this is a really significantly changing landscape. And pneumococcal vaccines are not the cheapest vaccine. This is not flu vaccine from the cost to the government. And they do restrict access to free vaccine. And at the moment, we're in a position where we've got a review about to come out. We've got PCV15, PCV20 available, and I'm sure by the end of the review, PCV21 available. Suggestions that we're going to make different recommendations already for Indigenous from 25 up. So it's a complicated process, and I think the government is hoping that we get a reduction in the overall cost of the program by having competition between different companies who have different vaccines available. Now, we're already making some recommendations. The handbook says you can use 15 instead of 13, but the reality is that you have to pay for 15 and not for 13. So I'm sure no one's using it in general practice.
Mm.
So it's a combination of let's see what becomes available and can we get a new program. I'm hoping this goes to tender by the middle of next year. But overall, it is disappointing that we don't have a broader program, and most people will know that last Friday the PBAC gave the thumbs down to RSV vaccine and to RSV monoclonal antibodies for children. So, we are no longer the world leader in providing vaccines.
So that's actually an excellent segue, because I'm now going to talk about a couple of different considerations in the extremes of age. We'll start with children. We'll go on to older Australians, because I think something that goes under the radar is the impact of having a viral illness, a respiratory illness, as a predisposing factor to pneumococcal disease, and specifically invasive pneumococcal disease. For some background, we are, and Phoebe, this is so in your wheelhouse, we're talking about antimicrobial resistance and good antimicrobial stewardship. And we have been sort of trying to train people like GPs, like myself, not to reach for antibiotics at the sign of a winter virus. But then we're potentially teaching our patients to stay away from us, or failing to recognise when superinfection occurs. So I want to start with the children's example, speaking mainly initially about this really fascinating and problematic issue of viral illness predisposing to pneumococcal disease, and the often conflicting messages about antimicrobial stewardship, clinical review, and vaccination, and how that triangulation, we're not getting that right. So I'll start with you, Phoebe, and then I'll go over to the elderly population, Michael.
Yeah, thanks, Anita. So yes, in children, invasive pneumococcal disease, and really most of the invasive bacterial diseases, meningococcal, invasive group A strep, almost always follows a viral infection. That's certainly what we see either from following a diagnosed viral infection with a molecular diagnostic test, or with symptoms of a viral prodrome that has preceded that illness. Not always, but almost always in the vast majority of cases. From an antibiotic prescribing point of view, though, that wouldn't change our recommendations for considering a viral versus bacterial, particularly lower respiratory tract infection in children, because we do tend to see that the viral illness will precede the invasive bacterial infection. And so it doesn't mean that we need to start giving all these kids antibiotics to make sure that we're covering for the chance that they might be one of those very, very rare children that does get invasive pneumococcal disease or another invasive bacterial infection. But it's about educating families and saying, I know your child is very sick at the moment and is struggling with a viral illness, but I think that we can get them through this with some supportive care. I would, however, like to see your child again if they get sicker in the next week, if they stop eating and drinking, if they get very high fevers, become unresponsive, any of those concerning signs. We would want to suggest that they either go straight to ED or get back in touch with their general practitioner. But certainly the viral bacterial co-infection is a very well-known thing in children, but generally the viral infections will precede the invasive bacterial infection. So you do get that time course of the, preceding symptoms following the more serious disease.
I think it's important, because I think all general practitioners on the call tonight will be aware of the phone call saying, you missed my child's pneumonia. In actual fact, we didn't. It developed after the illness that we treated appropriately. And perhaps this is an amazing opportunity for greater collateral for GPs like myself to give to parents to understand those time courses, because it does worry us that we will be caught out that way. What do you find happens with older patients, Michael, with regards the viral followed by the bacterial?
Oh, the same thing. RSV, influenza, probably COVID are certainly predispositions to pneumococcal disease and invasive pneumococcal disease. And it's disappointing that vaccination didn't get the nod for any older people. It can still be available as a private script. We do cover flu reasonably well with the adjuvanted quadrivalent flu vaccine, although probably one of the components there is no longer needed. But look, I think we still need to focus on vaccination against pneumococcal disease, because some of it is de novo without a previous viral infection. And we have effective vaccines. Paul's indicated the latest vaccine, which mops up, if you like, about 80% actually of the serotypes that are causing invasive pneumococcal disease in older people. So these newer, more valent vaccines are really important. And the fact that we've currently got to wait till 70 to give just at this stage, PCV 13, I've given my thoughts on the chat there. I won't say any more. But the most important thing is to get the vaccine in the arm. I was in a meeting on the weekend, and one of my Singaporean colleagues said the most sad thing is to see an older person dying of pneumococcal disease in ICU and they've not been vaccinated. I mean, this was a preventable death. And it's tragic that people are still dying in ICU from pneumococcal disease, whether or not it follows a viral infection.
Yeah, it's the old person's friend, isn't it? But it's actually quite a preventable disease. And I think that we still lagging actually really far behind in Australia. There are, this is a fascinating, and I ask Paul, you may know the research, but also Michael, I know that you've asked yourself this question. In terms of Australian general practice, you may have clinics that are very close to each other and serve very different populations, but the offering of the pneumococcal vaccine can be vastly different from one clinic to another, one population to another. And Paul's already mentioned, in fact, that when vaccines are targeting at-risk patients, perhaps recognising those risk factors is a barrier to offering the vaccine. And we're all terrified of our regulatory environment and getting it wrong. So I'm going to ask all of you, because you've got an epidemiologist, we've got a paediatrician, a geriatrician, comments about risk factors we really need to have front of mind if you can't remember everything, and advice for reminding yourself to offer a vaccine that nobody's going to ask you for because they don't know they need it. I'll start with you, Paul.
Okay.
Thanks. Look, I think these are really important. I think the problem, because it's so complicated, that people don't learn that. I mean, I understand vaccines. I'm not a GP full-time. I don't do diabetes plans, asthma plans, all of the other stuff that general practitioners have to do. And so in order for this to work, it's got to be something that really makes it easy. And I think we need to attack it in two ways. One, we need to link to our specialist colleagues, because they do know that they're managing some of these people, particularly those people who are immune suppressed on Humira or JAK inhibitors or whatever, and they need to be involved in, we've got to do better with rheumatologists and various others. But we have to use the availability that we've got to try and do this. And my view of pneumococcal vaccines and many of these other is that people with chronic disease, I don't try and separate chronic respiratory disease into, fibrotic and blah, 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 and say these are funded and these are not funded. If you've got cardiac, respiratory, diabetes, and so on, you need a pneumococcal vaccine. There is a real opportunity at the moment for both this and for other things to use the new requirements for general practice to undertake audits and do things to actually get great benefit for your patients. I mean, I've been in 2 Aboriginal medical services recently where the coverage of pneumococcal vaccine for Indigenous people over 50 was absolutely appalling. I mean, in one of them was 6%. And the opportunity to actually put in a system that will review people as they come in opportunistically, as many of them do, most of them do, to say, have they had this, and then have a system that puts a note on the doctors or sends them to the practice nurse afterwards, is something that can really, deal with all of those requirements that you have to improve things for your patients in your practice. And so I try and simplify it. Don't separate out, this condition from that. Everybody with chronic disease needs a pneumococcal vaccine, and then try and automate it in some way in your practice to try and make sure that you get those people. And Michael and I are working with specialist groups as well to try and get them to think vaccine more often.
Look, we've got a great comment just before I move on from Jennifer saying, use the PneumoStart tool and get nurses to be proactive. And I've got to say, nurses in general practice are the biggest unsung heroes. So that can be very helpful. But I'll continue the conversation with you, Phoebe, because sometimes you think of kids and you're like, I've got it sorted. They did the NIP. Job done. There is nothing else to consider. So what about the at-risk child and other vaccines we need to think about?
So probably the most common population that would come across the general practice arena would be First Nations children. And they are quite frequently under-vaccinated in terms of coverage that we may be able to provide to improve their protection against both pneumococcal disease as well as meningococcal disease. In many states, First Nations children are eligible for additional conjugate and the polysaccharide vaccine, and they're also eligible for Bexsero in many states, but obviously state by state, you'll need to check your local regulations around that. So what we do know from children that do get invasive pneumococcal disease is that most of the time they're actually otherwise healthy children. We do recommend when children are diagnosed with invasive pneumococcal disease that they do have an immune system screen done, and that would normally be done by a specialist immunologist or by a paediatrician with some input from immunology. So it's not something that would be needed to be done in the community. But some of the common things that might, see children that are otherwise well still in the general practice arena would be things like children that might have functional or anatomical asplenia, some children with some immunoglobulin deficiencies who again can come across as otherwise thriving, well-growing children. Those are the sorts of populations that we tend to often find their risk factor when we go looking for what has predisposed them to being vulnerable to having invasive pneumococcal disease. But in the vast majority of cases, even when we do some further hunting, most of those children are otherwise immunocompetent.
Yeah, thank you. I'll go over to you, Michael, and what tips do you have? They changed our pneumococcal recommendations right in the middle of COVID, and I think the email went into everybody's spam box. Now we're trying to relearn, and so what have you observed in terms of keeping up to date with older Australians and patients?
Well, thanks a lot, Anita. Look, well, firstly, we have a very poor vaccination uptake rate and in older people, and we really need to do better. Immunosenescence actually starts at 50. If I can put my geriatrician's hat off for a moment and say older age starts at 50, at least as far as the immune system is concerned, everybody at 50 is an at-risk person, but particularly if they've got chronic diseases. So my advice would be to think about pneumococcal vaccination, particularly if you're going to be exposed to travel or through the Hajj or going off to Kumbh Mela or something. I would recommend that you think of pneumococcal vaccination even earlier than 65, but certainly from 65, where I put my geriatric hat back on, again, geriatrician hat back on, I just think everybody should be offered the best pneumococcal vaccine we have, even if they have to pay for it. But let's be even more specific. From 70, PCV 13 is currently funded, and for at-risk people, it's funded from an earlier age. We just need to make sure that everybody over 70 gets their PCV 13. And as Alison has said in the chat, and I thoroughly agree, people need to be aware of how devastating pneumococcal disease is. It kills you. It gives you meningitis. It gives you long-term frailty, disability. You go to a nursing home. Probably also predisposes you to dementia, but that's another story. So let's at least try and get PCV 13 into the arms of those for which it's funded. But please don't confine our practice just to those for which a vaccine is funded on the NIP. We've said the same with Shingrix. We should be giving that from 50. I've said repeatedly at talks, and I'll be doing the same again in a couple of days in Melbourne here, that we need to think of giving RSV from the age at which it's licensed, which is 60, whether or not the government decides to pay for it. These are vaccine preventable diseases, as is pneumococcal disease.
I think that's a fantastic, and I think many of us have presented together, and I think one of the things that comes out with these webinars is don't assume a patient will refuse a vaccine that's not funded. I think you can offer, and then they can decide for themselves, because many people who know they are at high risk understand how devastating these illnesses can be. So I think we should ask and not assume what their feelings are about non-funded vaccine. I think the understanding the drugs that you prescribe helps you to prescribe them better, I've always thought. And I think that there was a little bit toing and froing. We went from 23 back to 13, and you may be forgiven for thinking the bigger the number, the greater the protection. And now we've also got a pneumococcal or a PCV 13, and we know that there are other 15 and 20 available. But the numbers don't tell you anything except about how many subtypes you're protecting against. So, Paul, can you give us a little bit of information, or perhaps talk about how just the number on the vaccine is not necessarily arming us with enough information to value the vaccine, or perhaps to explain to patients why they are necessary, particularly when I know I've given 13 and now I'm giving 23 and I may be doubling up. How do we deliver a spiel for ourselves and for our patients?
Anita, I approach this very basically. I think there are three things important in a vaccine program. Convincing the patient that this is a serious disease, and probably one of the reasons we have such vaccine fatigue and vaccine hesitancy is that the government wants to convince people that COVID doesn't exist anymore at a time that we've got people, dying by their dozens in nursing homes. If people understand how severe pneumococcal disease is, then they will enter into a conversation. And then after that, it's two parts, is the vaccine effective? And is the vaccine safe? And so all you need is, this is a really nasty disease and I want to protect you against it. And then I have a vaccine that is incredibly safe and a vaccine that is effective. And so that's the message for patients. And I think debates about 13, 15 or 20 aren't at the level of the patient. What's important is that the GP understands what's available and what's recommended by a ATAGI or by scientists or whatever, from the point of view of giving the vaccine. Funding doesn't matter. That's a government fiscal issue, not a scientific protection issue. My view with the cost thing, and I mean this came up a lot, particularly with Shingrix before it became funded, is that we did really well at convincing grandparents to pay for a vaccine to protect their babies. We didn't do as well to convince grandparents to buy a VZV vaccine to protect themselves. They were more worried about the babies. But when my patients with young children come in and we have a Bec Zero discussion, it's about, if this is too much for you or your family, if this is the difference between a school lunch and not a school lunch, then do you have an uncle who might want to buy it for you, or do you have a grandparent who might want to buy it? And it's the same with, these pensioners in homes and whatnot. Do you have a lawyer son in Melbourne who's, who could perhaps cut back on his, his specials and provide this vaccine for his mother or somebody else in the family who would do it? That you don't personally have to have the money, but you do personally have to get the protection. I think that's what's important. Disease is bad, vaccine's safe, the vaccine's effective. I want you to have it. The government pays for it. I'll give it to you. The government doesn't pay for it, but can we look at a mechanism for you to get it anyhow?
So Phoebe, we know that we do have vaccine fatigue. We know that in particular parents had to make decisions about COVID vaccine for their kids. There were some reasonable questions about, am I actually doing any good to my child as opposed to society? So if you've got a child who, and I know that the at-risk child is not as common, but I think the conversation is common. So a child who's completed their 13 course, but would benefit from a 23, what do you say when the patient's parent reasonably says, but you just vaccinated me against that exact thing, and now you're giving me the same, the only thing that's different is a number? How do we talk about we're not over-vaccinating, over-servicing? It all seems the same to the person receiving the vaccine.
So for the 23-valent pneumococcal vaccine, usually there would have been a gap between when a child would have had their conjugate vaccine course and then received their first 23-valent dose. So really that is largely recommended for high-risk children, as well as some First Nations children in some states, from 4 years of age. It is licensed from 2 years of age, but the current recommendations from ATAGI are for that to be given from 4 years of age, largely to promote immunogenicity for this vaccine, which is why it's recommended a little bit later. So most of those children will have already completed their conjugate vaccine course by 12 months of age. So, you know, whether they had a 2+1 or a 3+1 course, the last vaccine that they would usually have seen for pneumococcus would have been 3 years ago. And generally we do find that, you know, parents are very attuned to the, you know, terms like sepsis and, you know, overwhelming infection and meningitis. And when it's explained that that's the disease phenotype we're trying to avoid by giving some additional protection with this further vaccine, when the last one has usually been given quite a few years ago, most parents are very willing to accept that vaccine.
Yeah, I think, yes, and I'll come back to you, Paul. Yes, painting the picture of what we're preventing. Pneumonia, that may or may not cut the mustard, actually, because we've been dealing with so many viral pneumonias. I don't know what people think anymore. Sepsis and meningitis, I think, are big and very scary words. So, Paul, what's your thoughts on that one?
Look, I think that we're getting better at having discussions with parents about things that aren't just, you know, broad-based and global. In most of Australia, a dose of meningococcal B vaccine is not available for free. But we do give a quadrivalent meningococcal vaccine to parents. And when they've done some surveys, parents have been quite surprised to find out that they're not actually covered, even though they had the meningitis vaccine at 12 months. And so I think, you know, those parents were already having discussions that there's different types of meningococcal disease, and this vaccine protects you really well against these ones, but we need another vaccine to protect you against the other. And the same applies to pneumococcal disease, that, you know, we have protected you against 65 or 70, 75%, but we also need to try and protect you against the other ones. And therefore, we suggest that, you know, you have an additional vaccine. I think the use of polysaccharide vaccine will decline dramatically when we start to get these, you know, larger valent effective vaccines that are conjugated. I mean, the problem with polysaccharide vaccine was a little bit of uncertainty about its protection against pneumonia as distinct from its protection against invasive disease, and, you know, a degree of concern about the duration of protection with polysaccharide vaccines. And I think that, you know, I suspect we will not be using them, you know, in 3 or 5 years when we've got embedded larger valent conjugated vaccines.
So, Michael, from the point of view, there are so many vaccines that I can and do. I do love vaccinating people. In my older population, there's actually rather a menu. So how do you come at the discussion where you've got in amongst your 2 Shingrix and possibly RSV, and we're always doing flu, and then potentially you've got 2 of these pneumococcal vaccines to time and to give? How do you go about explaining to older patients that why we've got potentially two vaccines, what are their role and why both are worth pursuing if you're at risk?
So certainly for the at-risk person, as you know, we do recommend PCV, the conjugate, and then the polysaccharide. And I think we just explained that firstly, the conjugate gives a good immune boost. And if we give the polysaccharide first, we don't get such a good response to either vaccine. So we recommend giving the conjugate followed by the polysaccharide. And the polysaccharide, in some respects, mops up many of the serotypes that are missing in the conjugate vaccine. So this is where numbers do mean something. But as Paul said, it's important to just tell the person, these are the effective vaccines. These are the ones that are recommended. In the non-at-risk, if you want to use the current NIP definition, it's just PCV 13. So that's a fairly easy conversation. You've turned 70, get your vaccine now. Although, as you heard me say earlier, I think it should be started a little bit earlier. I think the conversation is we want to give you the greatest coverage. And there was some concern in the past, as Paul said, that these vaccines aren't particularly effective against pneumonia. They do have some efficacy. We've seen that with what's called the Capita study in Holland some time ago, but they're mostly effective against pneumococcal disease, either pneumococcal caused pneumonia, not all pneumonias, and invasive pneumococcal disease. Excuse me. And these are bad diseases to get. So I just simply say to my patient, you're older, you're immunosenescent, you need to be protected against pneumococcal disease. Yes, there are other vaccines that need to be discussed, as you said, Anita, and that number is increasing. But isn't that a good thing? I mean, when I started on this journey 30 years ago, there was just flu vaccine. Then pneumococcal disease became vaccinatable, really only about 1990 in Australia. Now we have such a large choice, and we really need to try to have a sensible discussion with our patients. I do like the comment on the chat that we shouldn't talk about free and not free vaccines. We should talk about effective and funded vaccines. That's a much better discussion.
Now, I do want to just, because general practice, I've got to tell you, you've got to love a little bit of chaos and uncertainty if you want to be a GP. And people don't come through this program in a linear fashion. So, for example, if I have someone who I've never met before, I realise they've got chronic kidney disease, I'm going to treat them as I just say, I meet someone who's 60, chronic kidney disease. Or let me make it even harder, 68. And I know that they've got their PCV 13 coming up at 70, and then you've got to do the timing to get this right. I find that sometimes the timing can twist you around in knots. And when is it optimal to have these vaccines compared to each other? Because as Paul has said at the beginning, you can perhaps interfere with some of the effects of the vaccine when you're tumbling over yourself to get everyone super vaccinated. So what advice do you all have for when I recognise that someone's at risk, I've got to do the at-risk pneumococcal vaccine, but then I've also got to remember when they turn 70, then it's PCV 13 time, as well as the other things. So what advice do you have about GPs who are thinking, well, I can't fit the timing into my head as well?
Personally, I think you treat the patient, not the program. And so if somebody comes in, they're 68, they've got chronic kidney disease. I don't know what they've already had, but that's something that I'd want to know, depending on the time of year. There are 6 vaccines that I consider critical for older persons: COVID, pneumococcal, flu, RSV, shingles, and pertussis. And so the person that you are talking about who presents to you for the first time, one of the discussions is that they need a whole series of vaccines because they are prone to get significantly, serious disease with their condition. And then it's really a matter of working through what they have had, what they haven't had, and then, what the process is from there. I mean, if it's flu season, obviously you want to, at this point in time, try and avoid Shingrix and an adjuvanted flu vaccine, just because we're not sure about the reactogenicity issues and so on. But, I think the important bit is to be clear about the overall program and then to come to an agreement with your patient about how you're going to go about giving them. I certainly don't suggest one every 2 weeks or something. I mean, the more that you can give them at the one time, the better, because there really is no problem. And while there is an issue with adding valences to vaccines, that they do start to intervene if you have PCV 30 or 40 or 50. It's not an issue with giving 2 non-live vaccines or 3 or 4 at the one time. They will all still work, and we do recommend, that we give them, so that, your patient would probably, leave with a couple of injection sites on both arms at the end of that particular consultation, because I think it's important that they can do that.
And just to make it, sorry, Anita, just to make it clear, I don't think Paul was meaning that the different vaccines interfere with each other. What he was saying is the more you put on a conjugate PCV, the less immunogenic each of those components is. So he's talking about the effectiveness of a single vaccine deteriorating, if you like, if you try and put PCV 30 or PCV 50 or PCV 103. That ain't going to cut the mustard. But Paul's absolutely right. Give as many vaccines as you can in as quick a time as possible, perhaps avoiding giving 2 adjuvanted vaccines together, such as Shingrix or RSV or Fluad Quad. They're all adjuvanted vaccines.
So if I give my patient with chronic kidney disease the polysaccharide 23 at age 69 and a half, do I give them the 13 at age 70?
I would not give your chronic kidney disease of PPV 23 at 69 and a half. I mean, we know that giving that there's hyper-responsiveness if you give the polysaccharide vaccine first. So while they're both still available, I would give a conjugated vaccine at 68 when you first saw that person, and then subsequently you can give them a polysaccharide vaccine.
Okay, so that is...
And I think, and Anita, this is clearly why we do these sorts of things and why we have the Pneumo Smart tool and all of the rest of it. This is a complicated area, and GPs need to be able to get simplified approaches to this so that they can actually protect their patients without being, right across the detail of funded, non-funded, which of these, some of the documents in the handbook say things like, this vaccine is funded if you have chronic kidney disease stage 4 or 5, and it's almost like if you've got 2 weeks left to live, we'll pay for the vaccine. I think that there's a better approach, which is, I want to care for you as my patient, and this is what you need.
And a moment ago, Anita, I said that RSV is adjuvanted. There's actually 2 RSV vaccines, I should make it clear, one of which is adjuvanted, one of which is not.
So I just want to ask this fascinating question. I don't know if you will have a neat answer, but in particular, Phoebe and kids, because we are, I think, have sparked some interest with the child that returns with the pneumonia. Are there any evidence-based strategies for treating a child with a viral respiratory tract infection that lowers the chances of them going on to have either bacterial pneumonia, which is more common, not necessarily invasive pneumococcal disease?
Well, I guess the first thing I would say is that the vast majority of pneumonias in children are still from viruses. So, we don't just see the upper respiratory tract infections from viruses. The vast majority of pneumonias in children are still caused by viruses. And there was a very good study called the PERCH study that quantified this a few years ago, and really RSV, as we all know, is the big one. But, many other viruses, human metapneumovirus, parainfluenza, lots of other viral causes that drive the great burden of disease. So just because a child has pneumonia, they don't necessarily need antibiotics, because that in itself is still often due to a virus. But that rare proportion that go on to have a bacterial pneumonia or another invasive bacterial disease following a viral infection is incredibly difficult to pick from as a needle in a haystack. And as I've mentioned many times tonight, almost all those children are otherwise previously well children. And it is just about constantly having that safety netting advice. We do know that with strep pyogenes, for example, group A strep, often there will be a more virulent form of strep that other household members or close contacts may have had carriage or an invasive disease of. And that's why we do household prophylaxis after invasive group A strep. For strep pneumonia, it may well be that there is also that close contact where close contacts have carriage of the serotypes more likely to cause invasive disease to a child that happens to then, you know, pick that up having had a recent bout of a viral illness. But there's no easy way to predict who that child will be. And the main thing is just making sure parents always know what symptoms to return to seek medical advice for, and whether those symptoms should be seen, you know, when the GP has the next appointment available, which could be some time, or when they should go straight to emergency.
Yeah, safety netting, and try your very best always to squeeze in the sick kid, I think. Look, I do have to draw this webinar to a close. I'm a little bit sad because I'm really getting into this, but we were promised a hard end. And look, I think if there are some key messages here, it's no patient's going to come in and say, can I have a pneumococcal vaccine, please? It just doesn't happen. It's going to be something we have to be on the front foot and ask yourself which ones and how many as often as you can, and offer the vaccine, because we are under vaccinating people at risk as well as just the general population. So I think that this is a really timely, and we probably underuse our practice nurses. So look, I just think I will have to bring this to the end of our panel discussion. It's to my sadness. I would like to thank each panel member for providing their expert input. It's been a fantastic discussion. And also to the audience, thank you so much for attending and for your interest. And we acknowledge our two sponsors who have helped us put this webinar together tonight, Pfizer and MSD. For those who wish to complete the reviewing performance case studies, we will be sending these to you via your email address for you to complete over the next few weeks. Great and an easy way to get points. And a certificate of completion will be sent to you for self-accreditation. And finally, and pretty please, do take 2 minutes to fill out the evaluation form, because that will be sent to you soon. Thank you all and good night.
Good night.
Thank you.